exploding secondary to we didn't provide enough moisture. Secretion has gotten very, very thick and nasty. Patients perhaps with dry, non-productive coughs, patients with increased airway resistance, increased incidence of infection. Again, it's all related to the mucus and how thick and viscous and tenacious the mucus is becoming. Folks with increased works of breathing, perhaps complain of substernal pain and airway dryness. And then the last one, again, my favorite word ever, those thick dehydrated secretions or inspissated secretions. You hear that word. And MBR, you know, you've heard me say it before, MBRC loves to use some of those fancy words that we might not necessarily say in practice at the bedside, such as inspissated, right? I don't think I've ever heard a respiratory therapist or practitioner at the bedside ever use the word inspissated. If they are, they're just trying to sound fancy. I'll go ahead and throw them under the bus right now. But that's a word the MBRC can use. And generally it's after the fact, and like, dang it, John, they said a word and I remember it, but I don't remember what it means. And they got me on that one because they used that word that we talked about week 6 of the first semester. And John, you never use that word ever again in the program. I know, my fault. Sorry about that. I'll have to make sure I keep saying inspissated for those thick, dehydrated secretions from air that we did not properly humidify. All right, I'm sorry.
I know one word we won't forget.
Maybe. All right, so this particular slide is not found in your textbook. It's something that was shared with me many years ago, and I like it. It makes total sense. So just stepping back, same picture we've had previously. So the cilia, the gel or mucus layer, cilia engages that mucus layer, slides it forward, disengages from the mucus, cleans themselves off to re-engage that mucus and keep pulling it forward. And again, we have how many cilia per columnar epithelial zone? 250, and they're moving how fast?
1,300.
Oh, you guys must have read something. Yeah, 1,300 times. You had a good instructor before me, thank you. To keep that moving forward. Okay, that's how it's supposed to work. And if we provide the moisture level at BTPS conditions, BTPS, body to temperature, pressure, saturated, if we maintain that, everything stays how it's supposed to stay. If, however, we don't provide enough moisture, so if this represents the 44 number, if we give a humidifier and it does not provide 44, and the patient can't contribute because we bypass the upper airway, the moisture level we're providing is going to be a lot less. For a time, and I don't mean days, I mean maybe an hour or two, for a time, airway clearance is still going to work normally for a very small period of time. Remember what I said here. I'm not talking days, I'm talking just maybe an hour or two. But at some point, the mucus becomes thicker. Because remember, if we're not providing enough moisture, where is the lower airway trying to get this moisture from? It's going to steal it from this sol or watery layer. So picture, each time our lower airway, which was never intended to provide all of the moisture of the gases we're breathing in, what happens to this layer? It gets smaller and smaller and smaller. So what happens to the mucus? It gets thicker and thicker and thicker. And so it gets smaller and smaller. The longer time, less and less moisture. So the cilia can't disengage. They get stuck in the mucus. They're trying to pull it forward and they uproot themselves from the columnar epithelial cell. All right, so mucus becomes thick. Over time, mucociliary movement stops. Mucus clearance stops. Cilia movement stops, leading to cell damage. Okay, and we know for a fact that's going to happen with enough time elapsing. So why don't we take it the other direction? Let's provide more than 44 milligrams. We'll make sure that those secretions stay super saturated, super thin. Well, guess what happens? For a time, mucus clearance is still normal, but mucus becomes thin. So picture this watery layer. Remember, in this upward example, you're providing more moisture. What happens to this watery layer? It increases. Cilia can no longer reach the mucus to pull it forward. it just simply just combs through the watery layer. But follow it. Mucus becomes thin, still leads to mucose clearance stopping, cilia stopping, and cellular damage. So fundamentally, it's still, if I give too little or too much moisture, problems are still going to occur. But problems will not occur if I do what? Keep the inspired gases that our patients are breathing in. Again, by the time that gas reaches the isothermic saturation boundary, that it's at PTPS conditions. Carrying how much moisture again? 44 milligrams of water per liter of gas. Okay. You're probably already sick of me saying 44, 44, 44, right? Like a game. How many times does he say COPD in a lesson for 44? I don't know what's the third most common thing I say. You guys probably know it and I don't realize it. What's that? God bless you. God bless you. Damn, people keep sneezing. What the hell's wrong with you? I'm just kidding. All right, so let's talk about equipment. Humidifiers. Humidifiers that we will discuss here. And this is just the beginning. This is not all of them. I'll kind of talk about the others more on Wednesday. So, a humidifier is simply a device that adds molecular water to the gas. Okay? Can you see humidity? No. The particles are too small. You cannot see it. Again, it's molecular water. Just like there is moisture in this room right now. There is moisture floating in the air, but it's way too small for us to be able to see or visualize. So for humidifiers, they use evaporation. Okay, evaporation to pick up moisture, to add moisture to the inspired gases. As far as what liquid is in that particular humidifier, it is sterile water. Sterile water. If it's not sterile water, distilled water could possibly be used. So if and where this is important, because typically I'm grabbing a humidifier, there's already moisture inside of it, there's already clear water or clear liquid in there, I don't need to worry about adding it. But maybe in a home care environment where somebody may be replacing or adding moisture, what, do I just get some regular tap water and run it under the sink? Absolutely not. Okay? We're not going to run tap water through our humidifiers. Why is that? All the stuff that is found in regular tap water cannot be used. So I know we understand that. We have to make sure our patients, when they go home and they're going to be using a humidifier that is not disposable, that is reusable, that they're going to have to physically add water to it, that they clearly understand you are not adding tap water to your humidifier. Our patients that are on home CPAP systems, they can moisturize the CPAP. You know, what should they put in there? Should they run that under the kitchen sink? Absolutely not. Sterile water or distilled water, but sterile water is the preferred.
Is that only because it could damage the equipment because of the...
And potentially create contaminants for the patient to inspire.
Okay.
But I'm being clear. Do not put tap water inside a humidifier. That's not the water we're talking about. All right, so humidifiers are affected by 4 different things. So 4 different things could affect how our humidifier performs. Temperature, surface area, contact time, and thermal mass. All right, the first one, temperature. The higher the temperature of the gas, the higher the temperature we heat that gas, the more moisture it's capable of carrying. Okay, so the higher the temperature of the gas, the more moist water vapor, more molecular water it can carry. And vice versa. The lower the temperature, the less moisture that can be carried. All right, surface area. The greater the area of contact between the water and the gas, more opportunity for evaporation to occur, more humidity could be provided. Time of contact, very similar to surface area. The longer the gas remains in contact with the water, the greater opportunity for evaporation to occur, the more potential moisture that can be provided. And then the last one, thermal mass, the greater amount of water in the humidifier, the greater its thermal mass and its capacity to hold and transfer that heat and moisture to the patient. Now, generally speaking, the last three, we don't really have a lot of control over, right? Other than making sure the humidifier is not dry. You know, they will run out of water from time to time, and in that case, you need to replace the humidifier or replace the water. But the humidifier itself, its design, you know, is going to affect surface area contact time. I really don't have a lot of control over that per se. But temperature, if I select a humidifier that can be heated, and not every humidifier can be heated, but if I select one that can be heated, and I know I can heat it, and the higher the temperature, the more moisture that could be carried, I need to remember that and recognize that depending on what type of humidifier, if I heat it, I can perhaps carry more moisture, and that means more moisture being delivered to the patient. All right, so this was a picture from the textbook on page 812 that describes humidification output. What's pictured here on the left represents a bubble humidifier. I'll talk about bubble humidifiers a little bit more in a minute, but represents a bubble humidifier. So the gas that's coming out of the wall outlet, again, bone dry, is going through here, and it's coming out underneath the water surface, and it's bubbling. So when you think of this bubbling, there's your increased surface area, there's your increased contact time between the gas and the water. That's coming through, and it's providing approximately 9.4 milligrams of water per liter of gas in this example, a non-heated humidifier. Okay? Don't worry about the number. I'm not going to ask that number on a test question or anything like that. There'll be some numbers I'll remind you, hey, you need to know that number for later. But just for the example, now if I heat the same device, run everything exactly the same as I did previously, but now I'm heating it, look how much more moisture I can potentially carry. From 9 to 51 milligrams per liter. And all I've done was heat the humidifier. Now, an aside here, bubble humidifiers we typically do not heat. So, bad example, I don't like the example they used here with a bubble humidifier, but at least you can see the higher the temperature, the more moisture potential that this humidifier can carry to a patient. All right, so talking about temperature. The higher the temperature, the more moisture that can be carried. So if you look at this graph, this picture is not from your textbook, but if we heat a gas, this represents moisture or absolute humidity. The higher the temperature, the more moisture will be carried. And if you notice, at normal body temperature, 37 degrees Celsius, we are carrying 44 milligrams of water per liter of gas. So that number go hand in hand. So when we are heating a humidifier, and I'm trying to figure out, well, what temperature do I need to heat it to? Why don't we go ahead and eliminate any confusion and say, well, if I heat the humidifier to 37 degrees, and 37 degrees Celsius is what that humidifier is set at, how much moisture is being provided? 44 milligrams of water per liter of gas. Now at 30 degrees, how much moisture is it carrying? 30 milligrams of water per liter of gas, which gets me to this 30-30 rule. You're not going to find this in the textbook, but it keeps it simple. At 30 degrees Celsius, if the humidifier is set at 30 degrees Celsius, it will carry 30 milligrams of water. For each degree we increase it, I'm going to carry a little bit more moisture. So for example, if I increase the temperature by 1 degree Celsius, I will actually carry 2 more milligrams of water. Hence this next chart here. All right, so 30-30. 30 degrees Celsius, carrying 30 milligrams of water. If you increase the temperature by 1 degree, you're carrying 2 more. So add 2 to 30, now you're carrying 32. Increasing the temperature by 1 degree higher, I'm going to carry 2 more milligrams per liter. Now we can keep playing this game, and you can see it keeps going up by 1 degree, carrying 2 more milligrams until we get to 37, and now it's carrying 44. I did give you guys this picture, didn't I? Okay. right? So if you walk into a hospital room right now and find that patient has a heated humidifier, and you find that temperature of the heated humidifier set at 36 degrees, how much moisture is being provided? 42. Is there a humidity deficit there now? By 2 milligrams of water, because you know you're supposed to deliver 44. Okay? The reason for the chart here is there will be times you walk into a hospital room and you're going to find the temperature of your heated humidifier is not set at 37 degrees. It's set at something less than. Right then, you should be able to tell me, or tell the therapist or the physician or whomever, how much moisture is being provided to that patient. And it might explain why that patient's secretions are a little bit thicker than they were when you and I had that patient yesterday and we had their humidifier set at 37 degrees. Questions? Yeah.
Oh wait, okay, so I was thinking that if you 30, 31, 32, you're increasing the bottom numbers by 2, but it's the top number. Okay.
If you increase the temperature by 1, you're
It's
carrying two more milligrams of water.
Okay.
Okay. I wish it was a simple 1-to-1 relationship. It would be much easier to see and to do. For every 1 degree Celsius, you're carrying 2 more milligrams of water.
And that's only.
But always start with the 30-30.
30-30.
30-30. You know when you get to the end, in case you're having a moment going, wait a minute, I'm getting out of sync here. You know how it's going to look on the end, right? 37 degrees carrying 44. You're just increasing temperature by 1 degree, adding 2 more milligrams of water for each single degree.
Why would you decrease the temperature?
That's a great question. I don't have a good answer for you. The question was, why would you decrease the temperature? That's the same question I have for every single person that does not set their heated humidifiers to 37 degrees. Why? Why? That's the question I have.
But there is anything that, I was thinking like you could add too much moisture, but you can, at 37 it will be a perfect one.
Right, normal body temperature. And I will say, to answer that question a little bit better, what some folks have the misinterpretation of, and I don't necessarily just mean the RTs, I mean even the physicians. Hey, man, that's a high temperature. I don't want to cook my patient's airway. We're not cooking the airway. We're setting it to normal body temperature. There is no, I'm not turning the temperature up to 110 degrees Fahrenheit and trying to burn them. Absolutely not. I'm just setting it to normal body temperature. And we know at normal body temperature, I'm carrying 44 milligrams of water. That's how our mucociliary transport system, normal mucus clearance, works best. Connor, you have your hand up?
Yeah, are there any concerns about heat being lost through the tube and like through
Yes.
the vent circuits?
Yes, absolutely. Now, don't want to get too involved into it right now, because that's part of Wednesday's talk, but I will say, I don't want to spoil the answer because we're going to talk about it more on Wednesday. Spill it. You have to say it, John. If I set the temperature high, and again, I'm talking about a mechanically ventilated patient with circuitry. If I set the humidifier to 37 degrees, so it's carrying 44 milligrams of water, and now it has to travel 6 feet to the patient, and the gas is allowed to cool, what's going to happen inside of the circuitry? Anybody know? Very good, condensation. And so now the fear for the RT is, now I have all this moisture in my circuit, is it going to drown my patient? Because and how we want that water to stay in the air. We want it to stay as molecular vapor water that stays in the air until it gets to the patient. And so that's something, we'll talk about that a little bit more on Wednesday without me opening my mouth too much, when the gas is allowed to cool. If we allow the gas to cool. rainout happens, condensation begins to form inside the circuit. When we want it to be, we want it to be moisturized, but we want running water in there. All right, so types of humidifiers. Yes, sorry, mate.
So would there ever be a reason to like want to create a deficit? Like say, if the patient is like contributing something, or you already want to.
Okay, so that's a good question. So if I know the patient, because their upper airway is intact, and again, if their upper airway is intact, they still can heat and moisturize their inspired gases. In that patient example, I do not have to provide them 44. I don't. But if we're talking endotracheal tube and I'm giving them bone dry gas, then I need to provide the 44 number. Okay, but if they're breathing like you and I, they just need a little bit of oxygen or some of our devices, I don't have to worry about providing 44 to them, because their whole ability to heat and moisturize their gas is still intact. I didn't bypass that. That's a good question. All right, so again, we're talking equipment here. Two primary types of humidifiers, those that are called active humidifiers and those that are called passive humidifiers. Active humidifiers actively add heat and water, or perhaps even both heat and water, to the inspired air that the patient's breathing. Examples could be bubble humidifiers, passive humidifiers, bland aerosols, vaporizers, the stuff we're going to talk about today. Okay, we'll talk about a lot of these active humidifiers today. Passive humidifiers recycle a patient's own exhaled heat and moisture to be used for the very next breath they're receiving. We'll talk about those today, talk about those more on Wednesday, okay, the passive humidifiers. But the design of each one of these and performance requirements are set forward by the International Organization for Standardization. So when it comes to the numbers, they set the numbers and what the numbers should be. Okay, we'll get more into that and what those numbers truly are a little bit more on Wednesday. All right, so let's talk about the first type of active humidifier. Again, actively adding moisture, actively adding water, or potentially heat, or both. The first one is simply a bubble humidifier. I know I didn't put it on the screen here, but make sure you recognize this is an unheated humidifier. So we are not going to heat a bubble humidifier. It breaks or diffuses an underwater gas stream into small bubbles. And one of the most common humidifiers you will see encountered in patient care that can be added to your nasal cannula. Again, the nasal cannula being the most popular, most common oxygen therapy device that's out there. Can it provide 44 milligrams of water per liter of gas? No, and it doesn't have to, because the patient's own upper airway is intact. When we say, well, how much moisture can it provide? Approximately 15 to 20 milligrams of water per liter. And it's really just a ballpark number there, but it doesn't have to carry 44. Okay, it's a bubble humidifier. Was that a hand about to go up? Go ahead.
Yeah, so, if you're providing too much moisture and you can still like do, cell damage or something like with the soy by providing too much moisture, and they're able to warm and humidify it with their own adding.
Right. A patient won't be able to over humidify their inspired gases. Their airway would just, let's say I'm going to pick on the high end here. This bubble humidifier can provide 20. Well, the patient's body's not going to have to obviously provide 44 anymore. But it's still going to make sure whatever the deficit that is there, it provides to compensate for that deficit. So again, by the time the gas reaches the isothermic saturation boundary, for that patient, that is carrying 44.
So you're saying the patient's going to stop providing his own moisture?
It won't have to provide as much if I'm providing some.
But will that kind of mess it up, because now that we're providing, and then if we take the humidity away, then
And the body will recognize, the body will recognize, well, you're no longer providing 20, so I'm gonna have to make up that difference.
it will be hard to kind of like.
All right, here's an interesting fact. Humidity levels decrease as flow increases through the device. So if I turn my flow meter on faster, more flow going through this, more bubbles, right? More bubbles, more bubbling, shouldn't that increase contact time? If I'm increasing flow,
It would be
actually
more
creates
rapid though,
less-
so.
Right, more rapid flow creates less contact time. And that's why humidity levels will decrease when I increase the flow on the flow meter.
So
I thought you-
basically like the higher the flow, the faster it's coming out.
The faster it's going through, the faster it's bubbling, the quicker it ends up going to the patient. So it actually causes less contact time as opposed to more. So the slower the flow of gas going through, so it's still bubbling, just not as rapidly, the greater the humidity output of the device. But let me be clear, what determines what sort of liter flow I set this to? How much oxygen the patient truly needs. Right, oxygen, and nothing to do with humidity at this point, just strictly, okay, they need 2 liters, they need 5 liters, they need 1 liter. I'll set it based on their oxygen needs, and I can understand, okay, humidity of this device can be affected based on the varying liter flows. But the liter flow depends on what oxygen concentration that patient is.
So 2 liters would probably provide around 20-ish, and maybe 6 would provide around 15.
Sure. And I'm glad you asked that, because I think I have a slide here in just a second. Actually, I got a little video here, again, so you guys can see it. I know you guys have probably played with these. Set them up. Everybody get a chance to set them up yet? Okay, that's good. Has anyone ever kinked or occluded the oxygen tubing? What happens when you kink or occlude the oxygen tubing?
Stop bubbling.
They're not
It'll
gonna,
continue, as long as the gas is coming through here, it's gonna continue to bubble.
Oh,
But if I
it'll-
kink the tubing,
it's gonna end up busting.
it will start to expand, and do you know what it will do? And I say don't leave it for too long, I mean,
Explode.
especially in the lab, because who knows how long we've had maybe that bubble humidifier and the integrity of the plastic, but it will alarm. It will actually make
Yeah,
a loud whistling
right.
sound because of the high pressure, the back pressure that's building up. They call that a pop-off alarm. Purpose, again, I would not intentionally want to kink someone's oxygen tubing, unless I'm just having fun, but it will make that loud whistling sound. But it's to let me know that when I turn it on and it's bubbling, there's no occlusions or blockages through the tubing. Now, do you think it happens when somebody is not intentionally trying to occlude it? What if the patient had oxygen tubing, that oxygen tubing's on the ground, and we roll a stretcher right up next to the bed, and the stretcher wheel just hits that tubing just enough to kind of smash it or occlude it, and we wonder, what's that loud whistling sound? It's this. Roll the wheel, get it off the tubing. Or my big fat feet come and stand on someone's oxygen tubing, and now I'm talking to the patient, not realizing I'm standing on that tubing, and now this is making a loud whistling sound. That's the pop-off valve. It's supposed to be there. It's an indicator that there's an obstruction somewhere in that oxygen tubing line. We can demonstrate that and do that in the lab one day so you can hear it. I just say, we don't want to do it for too long, because you will see, if you pay attention, you will see this bottle begin to kind of swell. My fear is that we keep it up, is it going to explode? I remember in school, we didn't have the fancy lab like you guys have now, but in school they told us about this, and so I'm like, okay, I hear you. But I want to hear what it sounds like. I was in a patient's room, and
Oh, so you
I'm looking at it,
you're one of them
and I don't
who
remember what I was in
purposely
there
did it.
for, but I had a moment, maybe I was getting a breathing treatment or something. I had a moment, I'm looking at just like it is right now, there's the tubing. I peeked it. It was so loud. Like, okay, I'm stopping that, and the patient stopped whatever they were doing. They look at me like, is everything okay? I'm like, everything's fine, sorry about that. It was my fault. Kind of played it off, but it was so loud. You'd be amazed. If once you hear it, you'll never not be able to hear it. When you're in a hospital room somewhere, you're walking down a hall and you hear that go off, you'll know exactly what it is and who's doing it. Oh yeah, some student in there for the first time wanted to hear it go off. Again, I don't recommend doing it when a patient's actually in the room. We can do that in the lab and jump and get scared and then laugh about it after the fact. Not in a hospital setting. All right, so don't worry about these numbers. Don't worry about trying to write these numbers or record these numbers down. I just want to show you this for various brands of bubble humidifiers. So they're not all the same. These are just various brands of bubble humidifiers. What's the humidity output based on liter flow? Remember what I said, the higher the liter flow, the less moisture output you're gonna see. And so if you just pick any random column from any one of these manufacturers, okay, at 2 liters, this one provides 17 milligrams, at 4 liters, 16, at 6 liters, 15.6, 8 liters, 14.6. The higher the liter flow, the less moisture that would be provided. But again, that can vary based on manufacturer as far as how much. Remember I said on the previous slide, a bubble humidifier can provide approximately 15 to 20, where you kind of think those numbers kind of come from. Just taking these particular, and there's more manufacturers than just these 4, but just some of the examples. So they can range just based on what brand we use in our hospital. All right, passover humidifiers. So a passover humidifier simply works as gas goes through, it passes by the sterile water, the moisture, and because of evaporation, it picks up some of that moisture and carries it on to the patient. Okay? 3 different types of passover humidifiers. A simple reservoir type, which looks like this. These can be heated, or they could be unheated, just depending on what our wants or needs are, but they can be heated. And if they're heated, what does that mean as far as moisture content? It can go up. Again, the higher I turn that temperature. All right, so again, if this is an example of one, so gas is going through here, it's going to pass by this sterile water, it's going to pick up some moisture and carry it on to the patient. But if I increase the temperature, that's going to increase evaporation, more moisture could be carried to my patient. You see this particular style on maybe a CPAP type or a BiPAP type machine. Now I know we haven't really talked about those therapies, but those therapies are provided for a patient with generally a very snug tight fitting mask, not down an ET tube, not down a tracheostomy tube per se, but they can be, but definitely not down an endotracheal tube. Generally with a mask, which means, what does that mean for the patient's own upper airway? Still intact. They still can provide moisture from their own humidification system. It's just with the CPAP or BiPAP, the flows tend to go through there at a pretty high rate. So we may want to be nice and add some moisture so it's not quite as drying to the patient's own airway. All right, so simple reservoir type passover humidifier. A wick type. With a wick, there's some sort of absorbent material inside that humidifier. And my best analogy for the wick style humidifiers, anybody ever go, especially during probably the springtime or something like that, when the mosquitoes are starting to come out, plus it looks cool in the backyard to have some tiki torches set up, right? And what's the liquid you put in a tiki torch? The citronella oil. And then there's this thing that you light that goes down into the citronella oil. A wick. Okay, a wick. So what does that wick do? It absorbs that citronella oil, so when you light the wick itself that's exposed, it starts to blow off some of that citronella oil and hopefully keep the bugs away, or at least the mosquitoes away. What does this wick do? It's submerged in moisture, so the wick simply absorbs that moisture. It ends up creating an increased surface area and increased contact time for as that gas passes through to pick up more moisture. Just a different style than the simple reservoir. Can be heated, which again is going to increase the moisture output. That's kind of another schematic of what we see in practice today. The red bars represent the wick. Okay, so these wicks are saturated with that sterile water. As the gas goes through, greater opportunity for contact between the water and the gas to be able to pick up more moisture. Again, these things can also be heated. Anytime I say a humidifier can be heated, that means it's capable, as long as I set the temperature to the correct degree, it is capable of providing 44 milligrams of water per liter of gas. So anytime you hear me say something, oh, it's a humidifier that we can heat, that one can provide 44 milligrams. If we don't heat it, then it can't provide 44. It's going to carry something less. Another one, membrane type. Again, similar to a wick, this membrane does retain and absorb moisture, so as the gas passes by, has a greater opportunity to pick up moisture. Again, can be heated, so it's still capable of providing 44 milligrams of water per liter of gas. Question? Sure? All right, so hold on, let me look. Make sure. Okay, I'm not gonna ask it here. If I have a patient with a bypassed upper airway, and based on what we have been taught so far about types of humidifiers, I have a patient with an endotracheal tube. You just got to intubate them. Damn it took 6 tries, but you finally got them, and they didn't lose any teeth. You finally got them intubated. What type of humidifier am I going to put for that particular patient? Options are bubble, simple reservoir type, wick type, or membrane type. Which one would you recommend? There could be more than one right answer. Wick, membrane, potentially simple reservoir, but what's the operative thing about all of these? As long as they're heated. And what temperature are you going to set that to?
37.
Thank you, 37 degrees, because at 37 degrees you're carrying 44 milligrams. So when I ask that question, all the following except, I'll rephrase it, of course not a bubble humidifier, because you can't heat a bubble humidifier.
Would there be a time where you would set the temperature a little higher to outweigh the
Generally no.
temperature loss?
Generally no. Notice I said generally. I try not to talk in absolutes, but generally no. I shouldn't even say anything, but I'm going to go ahead and open my big mouth. If a patient has an extremely low body temperature, and we pulled them out of environment where it was really cold and we're trying to warm them up, warm heated fluids, things like that, it may be possible to add a little bit more heat, even though we're not going to get crazy with warming the inspired gases, exceptionally high. It is possible to see a temperature a little bit higher than 37 in that scenario, just as we're trying to warm the patient's core body temperature. All right, the last one that was mentioned here is a vaporizer humidifier. Things you can go buy at the store today or on Amazon today that simply adds moisture to the air that we're breathing in to help moisturize it. Sometimes they're called room humidifiers. They're fine. Maybe it's for a child who's really congested and they're suffering with croup or something like that. That's okay, just to kind of increase moisture in the air. But you would not see these used really in a hospital setting, because what do you think bacteria, microorganisms, what sort of environments they really, really like? Warm, moist environments. They really love those type of things. So the room humidifier, as far as thinking in a hospital setting, we'll put one in this patient's room, and it'll just affect this patient? No. I mean, it's going to get into the air, it's going to go out the door, down the hall, into the next patient's room. So you really don't see something like this used in a hospital setting, institutional setting. In the home, it's different, it's fine. But at the same time, I wouldn't say I've been using this thing straight for 3 months and I never once cleaned it out or anything like that. Because again, even in the home, it can be a breeding ground for bacteria, microorganisms. You wonder why the water is a little off color there too. Yeah. Should be nice and clear. All right, any questions on the humidifiers, at least up to this point? I told you this was short. I told it was going to be short. So my questions for you guys, my questions for y'all. First question, normally by the time inspired air reaches our isothermic saturation boundary, it is conditioned to BTPS conditions, which includes A, its temperatures at 37 degrees Celsius, B, it's carrying 47 milligrams of water per liter, or 47 milligrams per liter of water, it's at barometric pressure, or D, it's 100% saturated with water vapor. hearing D, I'm hearing both B and D. I'm hearing A and D. Correct answer? Anybody know? It's A, C, and D. It's everything but B, right? How can I make B a correct answer? If I would have said 44, not 47. Okay, body temperature, pressure, saturated. So normal body temperature, 37 degrees Celsius, carrying 44 milligrams of water per liter of gas, which means it's 100% saturated.
ACDC.
C, D, okay. That helps, there you go. Alright, so everything is correct here except for B. And we can make B correct if we would just change that 47 to 44. Alright, next question. All the following affects the quality of a humidifier's performance except, alright, so temperature, options are temperature, thermal mass, contact time, surface area, or oxygen concentration. All the following except. What's the exception? Which one? I'm sorry, I didn't hear. E. Okay. All the following except oxygen concentration. All right. So temperature, thermal mass, contact time, and surface area are the four things that do affect a humidifier's performance, but not oxygen concentration. And you know when we are providing humidity, we're providing a gas, and generally we are providing oxygen with that gas. But the oxygen concentration does not affect its humidifier's performance. Alright, so correct answer here is E. Next question, as gas temperature increases, its capacity to hold water will increase, decrease, or remain unchanged. Increase, decrease, remain unchanged. You increase the temperature, you increase its capacity to hold water. So this one is A, increase. And vice versa. And vice versa. So if temperature goes down, capacity to hold water will also decrease or go down. Next question. If we provide an intubated patient a humidifier that can provide 36 milligrams of water, what is its body humidity? Yeah, there's no multiple choice here. It's fill in the blank. So what are we going to do with that 36? We're going to divide 36 by 44, which gives us an answer of 0.75, 75%, 81%, 81 point something. I think I may have rounded up. Yeah, about around 82%. But you see where we get that number from? Taking 36 and dividing it by 44. Again, 44. I'm not going to give you that number on the test. I'll give you the 36. But you have to know you're going to take that 36 and divide it by 44. Follow-up question. What's its humidity deficit? Okay, so the difference between 44, what we know it should provide, minus what we're providing here with this humidifier. So 44 minus 36, which is 8. Okay. Any questions on either of these? These are pretty simple math. Not like some of the other stuff we're doing in the other class, right? And wait till today. What's the weather supposed to be like today? Or should I say tonight for the game?
It's supposed to clear up.
Supposed to clear up for the game?
That's what they say.
Oh, yeah. Who knows?
You know how it
Yeah.
is.
Yeah. You shouldn't.
Oh my gosh, that's crazy.
It's a gift, sorry. Yeah. Rain all you want right now, but save it for so it doesn't rain tonight. All right, last question. If a respiratory therapist is using a heated humidifier device and the humidifier is heated to 35 degrees Celsius, how much humidification is the patient being provided? So what are we doing? Remember 30-30 rule. 30 degrees, carrying 30 milligrams of water.
35 has 5 more, you multiply by 10.
Okay, so each degree we increase, add 2 more milligrams. So at 31, so at 30 we're carrying 30,
38.
31 we're carrying 32, 32 we're carrying 34, at 33 we're carrying 36, at 34 we're carrying 38, at 35 we're carrying 40. Hard to do. Out loud, without missing, forgetting the step. All right, so at 35 degrees, how much moisture? 44. So that's, or excuse me, 40. Sorry. Programmed to say 44. I'm sorry. I'm programmed to say 44. So yes, you're right. At 35 degrees, carrying 40 milligrams of water. But again, where that question's coming from is that kind of step word table, if you will. All right, but that's the type of question you may see on the exam. All right, so I can make up whatever the temperature is, but I promise you the temperature will be somewhere between 30 degrees and 37 degrees. All right? All right. Any questions? No? Nothing? You guys are quiet. Chat, question? You're looking. Seriously.
If it's 35, it would be 40.
40.
Yeah.
40.
Right. He messed up and said 44.
Yeah, my fault. I said 40.
I'm like, okay.
At 30,
just
at
times
37
the-
degrees,
Yeah, that's
maybe
why-
I can ask
by
this
2,
question on the test.
really.
Yes, you don't have to do the step word thing. At 37 degrees, how much
Well, it
moisture
goes
is
up.
carrying?
It goes up
44.
every
Yeah.
one.
You know that already. Boo, you know, I know you know that one.
Maybe it'll be a good one.
No.
All right, so I have 1040, and that's my last question, yeah. I have 1046, 1047 right now. I'm going to go ahead and just round it up and call that 1050. Can we start back in here with our second class, say 11, because I want to give you guys at least 30 minutes to decompress. So why don't we start at 11:30, half hour earlier, 11:30 instead of 12. So we'll start back at 11:30 p.m., right? If you want to show up. Start back at 11:30, and we'll do the second class, and I'll get you guys out of here 12:30, 1 o'clock-ish. Okay?